care proxy process, advanced care planning. We're also going to discuss some available resources that the government of Manitoba has, as well as the Archdiocese of St. Boniface. So autonomy is likely the principle that you are most familiar with. It is something that is pretty common in our day-to-day vernacular, but effectively it means that an individual person has the ability to make a choice based upon their own philosophical or religious beliefs. And I use philosophical very widely here. This includes the value systems that someone has been raised with or ascribes to. This includes whether a person has a spiritual practice, a secular practice, etc. But effectively, it is the ability for a person to make choices based upon whatever value system that they have. And we are, as human beings, generally speaking, a combination of a variety of different value systems. We may identify as one spiritual or religious practice, but we, of course, are impacted by things like the society we're in, laws, communities, cultures, etc., when we make our choices. Now, when we think about autonomy, we are often very focused, of course, on an individual making a decision. And particularly in a healthcare setting, we are very focused on a person making a medical choice. However, how does it actually work in practice? So, an autonomous choice in a healthcare setting really is focused on, does this person have the ability to give informed consent? And what we mean by informed consent is, does this person have the ability to understand risks, benefits, consequences, and alternatives? Now, really importantly, particularly in a Canadian American healthcare context, we often refer to autonomy as that person, that patient, that resident, that client. They need to make decisions regarding informed consent. But there are many cultures, ethnicities, different places, different family structures where a person may actually make an autonomous choice to defer to another party to make decisions on their behalf or conjunction with them. This is different than a person lacking decision making capacity, and we'll talk about that in a moment. This is really more of a group decision making model or a deferred decision making model, but the same principles stand where we want there to be informed consent. So, do we understand benefits, risks, consequences, alternatives? In the event that we do not have that ability, because our patient is lacking decision making capacity, and we'll talk about how that can occur in a moment, we then will look to a surrogate decision maker to assist in that process. Really importantly, the goal of informed consent, particularly in a healthcare context, is that we're actually engaging with our patient, resident, and client about where they are in their healthcare journey and the decisions that they need to make. Now, importantly, when we talk about this, it's important to think about decision making capacity versus lack of decision making capacity. Now, very frequently, and it's not meant with malintent, but people often say, oh, that person lacks capacity or is incapacitated or is incompetent or a variety of combinations. What we're actually really focused on in healthcare is, does this person in this moment have the ability to understand risks, benefits, consequences, and alternatives? Specifically, about one given decision or a couple decisions, not about every single decision. So, an example that I use when I talk about this is the notion of the sundowner effect. So, the person who is living with dementia at 5 a.m. may be able to engage in decisions. They may be able to consent to a blood draw. They may be able to tell you what they want to eat. But potentially by the time they get to 3 p.m., they may not have the ability to do so. It's not fair to say that that person is incapacitated. That person may not have the ability to engage in a conversation about surgical decision making, but at certain points during the day, that person is able to engage in decision making. And that's why we refer to it as decision making capacity versus lack of decision making capacity. And for all intents and purposes, a surrogate decision maker only comes into play when we have lack of decision making capacity, and we'll get there in a moment. So, who actually does that assessment? Physicians, psychiatrists, not people like me, not nursing staff, not family. The decision making capacity for the purposes of a healthcare decision is made by a physician or a psychiatrist. Now, any physician, it can be a resident, an attending, and then typically what often happens is if a physician doesn't feel comfortable or there's a concern about an underlying psychiatric condition, that may be impacting decision making, they will then put in a referral to a psychiatrist.
Katarina,
Yes.
the slides are not playing.
Oh, interesting, because they are playing on mine. So let's just stop sharing for a second. Thank you for stopping me. Let's share again. Okay, can you see the slides here on the side?
Yes, we can see the side on the slide.
Okay, Odd. I'm just gonna start in presenter mode. Okay, can you see them moving?
No, we're seeing probably your other screen. So no. Oh, moving, yes.
You're seeing them moving?
No.
No. Okay. So we're just gonna stay, for all intents and purposes, we're gonna stay here. Okay, so you can see this presenter mode you can see the slides on the side and you can see it moving here.
We're not
Correct?
seeing any slides right now.
You're not seeing any slides. Okay, let's try this again. Okay, do you see them moving over here?
Yes.
Okay, so for whatever reason, when we get into presenter mode, it's not moving it along. So we bear with us, we'll be on this side. Okay. So importantly, when we think about who will actually make decisions, it's important to realize that the presumption age in Manitoba is that a 16-year-old or above is entitled to make medical decisions for themselves. So below the age of 16, a physician may determine that a minor is a mature minor, meaning that they're able to make limited decision making. But the presumption is that anything above the age of 16, that person is able to make choices on their behalf. Just a couple, we will talk about surrogate decision making in this group in a moment, but just keep that at the back of your mind. 16 or above are able to make medical choices. So, what are potentially situations or impacts on a person's ability to make decisions for themselves? So, it's really important to think about situational aspects, psychosocial. There may be very well an underlying medical condition, a psychiatric medical condition, or a physiological medical condition. Often we see persons' decision making is impacted by, for example, an infection, a concussion, some other events that has occurred in their medical history. But there are, of course, also situations where this is more situational. So if we take a person out of their environment that they're most comfortable in, and then we put them into a hospital setting, they may not be able to adjust as well and maybe be confused potentially in the process of making choices. So there's lots of different aspects that may affect decision making. Just really importantly, we are looking at differences in decision-making capacity. Really importantly, often it gets asked, well, this person may lack decision-making capacity for surgery, but a lawyer has come in to provide some legal support to this patient. That is a different capacity assessment. Those are capacity assessments that will be done by a lawyer. What we're concerned about is, does a person understand the risks, benefits, consequences, and alternatives of a medical decision? So really importantly, there is some terminology to keep at the back of our mind. So it's fantastic when we have a person who's able to engage in decisions on their own. And they may potentially want to engage in a group decision-making model, but they are effectively, let's call it, in charge of the process to make decisions. In the event that they lack decision-making capacity, we will then be looking to another party to make decisions on their behalf. So you may have heard of surrogate decision-making, or substitute decision-making, or third-party decision-making. They are all interchangeable words. They effectively mean that another person is going to make decisions on your behalf when you lack decision-making capacity. A type of surrogate decision-maker is a healthcare proxy, and we'll get into that in a second. But a healthcare proxy is a surrogate decision-maker, but they have greater authority, and we'll get there momentarily. So when you lack decision-making capacity, what happens? There are effectively three buckets in Manitoba to consider for substitute surrogate decision-making: the healthcare proxy process, the commodyship process, and effectively informed consent policies that talk about family or friends. If you're more interested, the Healthcare Directives Act of Manitoba lays a lot of this out. but we do have an act in Manitoba that talks about surrogate decision making. We're going to get into the specifics of those buckets in a moment, but regardless of which bucket a person falls under, there are two ethical standards that a surrogate decision maker have to follow when they are acting upon another person's behalf. The first is substitute judgment, which really means they need to put the hat on of the person that they are making decisions for. In my case, my husband happens to be my healthcare proxy, which means that he has to put on his Katarina hat and think about how do I make decisions, the lens that I take, what my values are, my preferences, and make decisions in accordance with that. In the event that he doesn't know, he has to move to the best interest standard. So a best interest standard effectively is meant to be more than just a medical best interest. It's meant to be a global best interest. It includes all of the aspects of a person's life. Importantly, healthcare professionals, of course, though, take the lens of a medical best interest. So when surrogates are having a conversation with our healthcare teams, it's really important to think about more of that global best interest on behalf of an individual. So a healthcare proxy process is the only process in Manitoba for a person to be able to appoint a healthcare decision maker that is legally binding. It is often a family or friend, okay, but occasionally it's another form of trusted individual. And effectively, what it means is that this person has now designated another party to make medical choices on their behalf when they lack decision making. It is also often executed with an advance directive, but it doesn't have to be, and we're going to talk about that momentarily. But it is probably the greatest preventative ethics strategy out there because it means that a person has the ability to designate and appoint another person that they think will understand, first off, their substitute judgment, and in the event that they're not able to look to a best interest standard. A couple rules around the healthcare proxy process. If you are 16 or above, you can make a healthcare proxy, but the actual proxy needs to be 18 or above. You can appoint more than one, so they can be consecutive or they can be joint. But really importantly, a proxy cannot appoint another person to act as a proxy, meaning sometimes we see where, for example, let's pretend like we have an older patient who happens to be a mother. She has appointed daughter A to be healthcare proxy. Daughter A says, no, I don't want to be proxy. Daughter B should be proxy. Daughter A cannot appoint daughter B. Only the mother can appoint daughter B. So a daughter B can act as decision maker under other rules, which we'll talk about in a moment, but they will in fact not be a healthcare proxy. The healthcare proxy has to be designated by the person who is choosing the proxy. How is it made? It can be done with a lawyer. I'm going to show you the Government of Manitoba form. Public policy has essentially allowed this process to be that a person can fill out a document or write on a piece of paper. There is no actual witnessing requirement. All the person has to do is sign and date it. If they physically cannot do that, then they need a witness to acknowledge what the document is. But for all intents and purposes, the vast majority of people just fill out the Government of Manitoba form and appoint who they would like as a proxy. We're really good at generally doing this when someone is admitted into long-term care. However, it's a bit piecemeal in every other environment. How can you create a new one? So old one is revoked by a new one. You can physically destroy it. You can write to say the old one is no longer valid. A couple other little fun facts. Divorce actually removes your spouse's proxy if you had appointed your spouse. But for many individuals, people are on still very amicable terms with their former spouse. And so sometimes people still want that person as their proxy, which means they have to create a new one after the date of the divorce. Where should you keep it? So this is part of the problem in Manitoba that we don't have a centralized system for this. So generally speaking, some recommended places to keep it are with your general healthcare practitioner, potentially on your fridge, a copy in your home that's readily available, that you actually give a copy to the person you've appointed as your healthcare proxy. You can give one to your lawyer, etc. So it's not a great system. It's very piecemeal, but again, the more that you give to people, the more knowledge that people will have that you have a healthcare proxy. What are some of the benefits of this? So it's really important because It can allow us to engage in a conversation with another person on your behalf. So we know potentially what your preferences are, your spiritual practices, your religion, potentially if there's any changes, potentially if you don't agree with entirely of your religion. And so it allows us to make sure that we are as accurately as possible reflecting your medical choices. Some of the disadvantages of this, though, are that we are now trusting another person to act upon your behalf. Healthcare proxies occasionally can feel very overwhelmed with acting as a surrogate decision maker. So that, of course, is another disadvantage. And there's just like a lot of process limitations of where is the document. And I'll show it to you in a moment. Importantly, there are limitations on healthcare proxies. So the Healthcare Directives Act in Manitoba carves out exceptions where a healthcare proxy cannot consent to sterilization. They cannot consent to removal of tissue for the purposes of transplantation. There also cannot consent to for the purposes of research. And there is a review process if there's potentially misconduct of a healthcare proxy. It is, in fact, a court process to remove a healthcare proxy if it appears as though that a healthcare proxy is not acting on behalf of the patient. So the healthcare proxy process is the only way for a person to designate a healthcare decision maker on their own kind of desires and preferences. There is something called the commodyship process in Manitoba, which occurs when someone falls under the Mental Health Act of Manitoba or the substitute decision maker for personal care under the Adults Living with a Mental Disability Act. This effectively is the process in which there's both private commodyship and public commodyship. Private commodyship is, for example, if I had not created a healthcare proxy or power of attorney, my husband could go through a court process to become my designated decision maker. It's pretty rare because it's costly. You have to hire a lawyer, you have to go through the court process, etc. What's way more common is that, unfortunately, a person falls under these acts, does not have a reliable family or friend to act upon their best interest to make decisions, unfortunately is likely to need decision making for a prolonged period of time, and has typically a touch point with some sort of healthcare organization where a process for application to the lead psychiatrist office to have a public guardian and trustee appointed occurs. And so effectively, you're examined that you need one. We do a social history. We then end up putting in a process to have one appointed. There is a petition process for objection. So if a person states that they feel as though that they don't need one, family can also come forward. Then the director will make a decision in the end, which will determine whether you are now given a public guardian and trustee or if you fall under the order of commodyship. There is no end date for this, though. This is effectively that a person will be under a public guardian and trustee. I have a lot of respect for what the public guardian and trustee's office does and the work that they do, but as you can probably imagine, they do not have the ability to do substitute judgment because they don't know the client that they are going to be assigned to. They are making decisions solely from a best interest standard. So there's the healthcare proxy process, there is the commodyship process, and then there is informed consent or our informed consent policies, which are generally speaking kind of sprinkled throughout healthcare systems. They effectively mean that if you haven't created a healthcare proxy, you don't fall under the Mental Health or the Adult Living with a Disability Act, which is now the vast majority of people who gets to make decisions. It is all available family and friends, and it is not legally binding, and nobody has greater authority than the other person, which means that there is plenty of opportunity for conflict in these scenarios. Typically, the recommended order is your spouse or common law partner first, then children and parents and siblings and grandparents, etc. But the three buckets that I see very frequently are adult children who disagree about what their parent would want, a partner of an adult that was not the parent that raised children, so there's disagreement between a parent's new partner and adult children, and similarly also parents of an adult who don't necessarily get along with the adult partner. Those are all three buckets of potentially disagreement that occur, but as one can imagine, this is almost too many cooks in the kitchen. Who is the designated decision maker? Who understands substitute judgment? Who can make decisions from a best interest perspective? And so there's often conflict. There truly is often conflict. This is the Government of Manitoba form. It's a great form for designating a proxy, so you can put proxy 1 or proxy 2. It is a pretty terrible form for treatment instructions. They give you 5 lines here. There's no prompting questions. And we're going to talk about advanced medical directives in a moment here. It's a great form for proxy, but just not fantastic for advanced medical directives. The Archdiocese also has a resource that is a bit more robust that will ask you some prompting questions, etc. So the reason why the government form is not an ideal form is that typically advanced medical directives I only recommend in 3 scenarios. 1, you are an older person. 2, you have a disease that has a typical trajectory. Or 3, you are in a scenario in which unfortunately you have a terminal diagnosis. And I only ever recommend doing them if you are doing them with a professional healthcare provider. And the reasoning is that there are so many nuances with specifics of advanced care planning that it can be very, very difficult to execute these documents well. Additionally, 5 lines, as you see here, is not sufficient typically to go over the types of preferences that you have. And they can be quite technical too. So it can be, in this scenario, I would like to receive X or Y. In this scenario, I may want to receive X or Y. Also, the reason why I don't recommend it for a generally kind of overall healthy person is that it's very difficult to think about how your preferences may change in the future. A healthcare proxy is going to know what your preferences are and hopefully adapt as time goes by. But these documents are actually, excuse the language, but they trump a proxy. If you write down what your preferences are here, those are the written word of our patient. So we are obligated to follow the written word of our patient. So what are some of the actual questions that come up in advanced medical directives? They include dialysis, intubation, resuscitation, things like hydration and nutrition, and aspects of antibiotics. And these are often kind of the general buckets that are considered with advanced medical directives. They're really great if they're done well because it is the patient's preferences. It also gives medical professionals a real guidance of what your choices may be. And so it is really a useful tool in those 3 buckets of terminal diagnosis, disease with a typical progression, or an older person. The disadvantages of this, of course, are that they need to be updated on a regular basis if you are going to create one and you don't fall into those buckets. And like similarly with the healthcare proxy documents, where is this located? It's also very difficult to account for every situation. So occasionally I see these documents and they will say, I don't want to live like a vegetable, or I don't want to live if I'm not experiencing joy. And there's way too much subjectivity to those notions that it's very, very difficult to make any sort of medical choice accurately from that. So really importantly, often that comes into the conversations about advanced care planning is this notion of ordinary versus extraordinary means in Catholic ethics. So ordinary means or proportionate means are medical decisions that have a reasonable hope of benefit and do not entail any sort of excessive burden. We have a moral obligation to use ordinary means under Catholic ethics. Specifically, that will include often things like hydration and nutrition. However, there may become a time in which hydration and nutrition become extraordinary means. Now, what is an extraordinary mean? An extraordinary mean is something that does not necessarily offer a reasonable hope of benefit or creates an excessive burden, or effectively the benefit, for example, may just simply be longevity and not overall quality of life. And so there is no moral obligation for extraordinary means. So there's no moral obligation that a person has to undergo oncology treatments. There is a moral obligation that we provide hydration and nutrition to a person who is unfortunately living with cancer. And so this is the big distinction where there's really no moral obligation to engage in most aggressive curative therapeutic interventions. But we do have an obligation to create the kind of what I typically call creature comforts. So food, water, creating an environment that is comfortable for the person in whatever decision that they may end up taking. And so hydration and nutrition are the big ones where, quite frankly, we see a lot of gray in this area because hydration and nutrition at some point can become extraordinary. People can no longer receive any sort of benefit. They may be experiencing fluid overload. There's a lot of conversations about the natural dying process, typically involves people not eating as much or drinking as much as they normally had. And so, for example, this opens up questions about the placement of a feeding tube. Do you place a feeding tube? Is it meant as a stabilization aspect? Would you place a feeding tube in a nose? Would you have a surgical intervention? However, arguably, if that is quote unquote the only thing that a person needs to continue existing, so a child who has potentially gastro related issues, but is going to live an overall typically normal life, the feeding tube would arguably fall under what is something called an ordinary means. Because if they don't have the ability to eat, but they have every other aspect to engage and live a full life, we have an obligation to provide that support. And so it becomes a pretty gray area, particularly in an older population and particularly in a population that may be at end of life. I'm going to stop sharing now because that's the kind of formal part of our presentation. And I encourage any sort of questions that you may have on this topic at this time. I'm also just going to shut my heat off in my office. Just one minute. My office is either boiling or freezing. So any comments or questions?
You can unmute yourselves now for those who have questions, or you can type it in the chat box. I have to unmute. Okay, there's a question in the chat box here. Is there a better health directive than the one you can get from Archdiocese?
Sorry. Okay. Is there a better health directive that we can get from the Archdiocese? So, from a health directive of like pointing out a healthcare proxy, it's virtually similar. The Archdiocese, there's a link that I had in the slide, which effectively can provide some advanced care planning process. But really importantly, you can do this with your clinician, like your healthcare professional is entitled to bill for having a conversation. So you can print off the Archdiocese form, but truly I do recommend that as a starting point, but having a conversation with your general healthcare professional to talk about your given circumstance, because everyone's situation is going to be very, very different.
Mm-hmm.
If there's no family or friends, does public trustee step in for proxy? It will depend on whether they fall under the Mental Health Act or the Vulnerable Persons Living with an Adult Living with a Mental Disability Act, and it will depend whether the lead psychiatrist determines that a public guardian or trustee should be appointed. So it's not automatic. That is a very formal process to be able to have a decision maker. Gladys, do we have a duty to prolong life at all costs? No, we do not have a obligation to prolong life at all costs. And that becomes, and I would say almost we have possibly more of an opposite approach. Our goal is to make sure that a person feels supported in their medical decisions, but longevity is not in of itself some sort of aspect of life that we need to focus on. In Catholic ethics, we're not meant to interrupt the life from conception to natural death, but there is, of course, this aspect of what does natural death look like, and natural death does not have to be prolonged or avoided. So that can include things like, for example, the person living with cancer may not want to undergo oncology treatments. There is no obligation for them to do so. Similarly, there's no obligation that a person is intubated if they end up going through cardiac arrest. So there are a variety of different circumstances where effectively we say, as long as we're not actively providing medical assistance in dying to a person, there's no real obligation to prolong life at all costs. It's a good question.
Mhm.
Any other comments or questions?
I just have a. Can I speak?
Catherine, yes, please.
Okay. I've been working in parishes, and then I was for 3 years, and who was fed through her stomach, and she had a stroke. So with the other hand, she would grab the tube and pull it out, and the family would insist that it be put back in. And then it was like, and I remember the doctor said to me, "You come and sit in this conference I'm going to have with the family." And you know what? I guess it went on and on and on, because I saw her name in the paper maybe about three years later. So that woman was like, I just felt, let her go, let her go. We have no obligation to. She's telling you something if she keeps pulling the tube out. She's saying, I don't want this, I don't want this. But anyway, I find that very painful and very difficult to deal with.
Yes, thank you, Catherine, for sharing. You cut in and out a little bit, but I think effectively your story was that you knew somebody who had a feeding tube that was trying to pull it out.
Yeah.
And there are lots of scenarios that are like this, and so there's often it becomes a further question of, do you then put someone with mitts on so that they're not pulling out their feeding tube, or do you involve other restraints? And so it becomes, yes, the person, often there are of course people living with dementia too, is this a new preference for them? And it's this balancing act of, are we prolonging life, or are we providing the basic necessities for that individual? And it's feeding tubes in particular are a difficult conversation, because if a person, for example, is like a younger person and they need this as a mechanism to eat, but everything else in their life, for example, is like a typical trajectory, arguably there is a moral obligation. If you're nearing the end of your life and we're placing a feeding tube and we can't engage in that conversation, it becomes really difficult for surrogates to have that conversation about, do we put one in or not? So this goes back to a question of, is there an obligation for nutrition and hydration as long as it isn't harmful? Broadly speaking, yes, except for when we're talking about the natural dying process for individuals, it becomes, what is the mechanism for nutrition and hydration? So we can't not provide food and water to a person who is living with dementia, is older, is actively dying. There is a separate question of, do I have to continue to provide IVs or feeding tubes in that scenario as well? So we have an obligation to provide necessities. It starts to become increasingly complicated mechanisms in which that could occur. So it's something to consider. It's not going to be a one size fits all approach. There's going to be lots of conversations about a person's underlying conditions as well.
Mhm.
There's a comment about, how does MAID fit into this? So there's two parts in which MAID can fit into this. So MAID, or medical assistance in dying, for those of you who are not as familiar, there's effectively two aspects to MAID. One is direct administration, which is the process of giving medications to end a person's life. The second is self-administration, in which a person takes a series of medications to end their own life. Overwhelmingly speaking, in Canada, it is direct administration. Direct administration is then a person goes through the process, they're assessed for MAID, they may be eligible, they'll have access to it, they may consent to having it. Where it actually comes into play with advanced care planning is actually very recent, but Quebec effectively stated that persons should be able to advance care plan for this. So they should be able to think about the future of having the option of MAID. Historically, the federal legislation has prohibited this, because the notion is that you have to be competent in the process of getting the assessment done, and you have to be able to engage in decision-making capacity for the actual day of administration. There currently is like a federal survey that's going around to see how others feel about this process, but I have to anticipate that there could be a potential change. But Quebec has been pushing very much for having advanced care planning as a component of this.
Mhm.
And yes, to answer that other component, it would be very, very difficult because I can't even imagine how this is going to work from a practical level. Like who is doing the advanced care planning? How often is it updated? What happens if a proxy says that a person has changed their mind? Where would those documents live, etc.? Like on a completely unrelated ethics perspective, to me, it seems like a logistical nightmare, but that is another consideration that is occurring. Any other comments or questions?
What about obliging someone who is against MAID to work in a department where MAID is performed?
Okay, so in short, your question is about conscientious objection. So in Manitoba, we have a centralized medical assistance in dying service. So it is a service that is consulted and then provides assessments and administration. Arguably, it's a little bit self-selecting. So if you, for example, don't want to be participatory in the MAID process, arguably you would not apply to be part of the MAID team. A separate conversation does happen, though, of if a patient is asking for the contact information for the MAID team, or they're wanting to reach out for more information and you don't feel comfortable. Manitoba has a lot of support for conscientious objection, so a person is not required to, although there is an obligation under most policies right now for you to find another person to then provide that information. So let's just take an example. If there's a nurse at St. Boniface Hospital, they would then contact another nurse or their manager to see who could provide that information if they do not feel comfortable to. There's a general recommendation that information needs to be provided within 24 hours to that person. So it's a good question, though, Catherine. Thank you.
Mm-hmm.
Any other questions before we wrap this up?
If you do have other questions later, if you don't feel comfortable asking them in this setting, or if you like think of something later, please do reach out. I'll pop my email into the chat.
Katarina, there's a question: are you okay, or are you sending the slides as well? Is that allowed to share?
Yes, no, that's totally fine.
Okay.
That's totally fine.
So we will send you all an email with a link on where you can actually find it. We're probably going to be uploading it on our website, including the recording of this session.
Perfect. Well, thank you, everyone.